Warm welcome to others who have joined as well. Let's start this. This session is our interesting experiences that we have had in being able to in conceptualize that whole idea of participatory leadership for building evidence-based mental health solutions for the CHWs. We are from the Resilience Collaborative. I'll tell more about the Resilience Collaborative soon. It would be nice for you to let us know where are you joining from and what inspires you to take care of your mental health and why, or who inspires you to take care of your mental health and generally why. I think that'll be nice for us to know till while others join. Please feel free to type this in the chat, or maybe you can unmute yourself and just speak.
Okay, can I speak?
Yeah. Yes, please. Yeah, please go ahead. Yeah.
Okay, so I am by God's grace, I'm Dr. Iveren Sylviates Ivase from Abuja, Nigeria, and it's good to be here. And basically, my life basically has been a life that I've had my own share of times that I've experienced mental health challenges. I've seen it in other people, and I've experienced, there've been times I've experienced burnout as a healthcare worker, and I've experienced a bunch of personal challenges, and I've come to see that it's at the core of who you are. Everything literally revolves around it, so you can have other challenges and still be able
Thanks
to.
for sharing that, Everin. Yeah, anyone else want to go, or maybe we can move on. I'll just quickly give an outline. I think we will be largely sharing our experiences with 3 specific activities that we had done. We had developed a toolkit for the community health workers. Rather than me saying we, this we includes definitely a large set of community health workers themselves, and it is jointly owned by all of them who have contributed to it. And we also manage a global community of practice, which is called the Resilience Collaborative, where what are the things that we do to improve the ownership and improve that participatory leadership is something that we want to reflect upon in this session. As well as we have initiated and we are running successfully a leadership course for the people who are members of the Resilience Collaborative, of those who have chosen themselves to be part of this cohort. And we have started off with a cohort of 12, and it's really going on well. And we would like to reflect on that experience as well. And we will also have some of those members sharing their experiences, and we will have an interaction with them of what this meant to them and what is that it translates into in terms of leadership and ownership. So that will be the session largely. So I'll quickly just sort of walk you through saying who we are. So I'll quickly start about the George Institute. We all are part of the George Institute for Global Health in India, which actually is a global organization with presence in Australia, UK, and in China. And now also we are beginning some activities in Africa as well, and South America has some activities as well. So we are largely a non-profit medical research organization. It was birthed by University of New South Wales in Sydney, and we are active bunch of 1,100 people globally who are really managing and executing some 245 odd research projects. So the research also includes an array of research, including implementation research, where we pick up activities like this, but the focus continues to be researching and evidence-based solutions for all that, or all in all the work that we do. What is the Resilience Collaborative? Resilience Collaborative is a global learning community that really advances or aims to advance learning and learning and driving the adoption of the evidence-based strategies, especially for building health workers' resilience, and with the focus continuously being on the lower and middle income resource settings. So that is what the resilience collaborative is, and it finds various ways to include people, not just include them, let them own it, let them participate in it actively, and move on this agenda for ourselves. So what are the aims? As I said, one of it is, one of it is to prioritize the well-being and resilience of HCW. I think that is one of the major work or the aims that we are looking at. And how do we do this? Through leadership development and capacity building, and also building the systems and building actually the solutions that can improve their resilience. And these solutions are properly evidence-based solutions that we can look at. And we are also looking to institutionalize the resilience collaborative with that is being completely led and owned by the community health workers and the health workers in general to take this work forward and strategically sort of disseminate the learnings that we learn to see how is that it can influence the HCW or HCW. We use the HCW and CHW here because we also work with the other healthcare workers beyond the community health workers alone. So see how is that we can improve the agency for them to be able to influence the policy. So that is where the strategic dissemination work happens, which is one of the core aims of TRC. What is that we have done so far? Or maybe these are few of the activities, major activities that we have done. So we did come out with a toolkit for program managers to be able to assess their needs of their organizations for building resilience amongst their workers. That is one of the core work that we have done. And now we have moved on from that, being from program managers alone, to be able to develop a toolkit with the health workers, which again included a large cohort of community health workers to plan and action the solutions that they build by themselves at individual levels and at the organizational level. So we also have some digital health products as part of which was developed as part of the resilience collaborative. One is called the Reach Digital, which is endorsed and which is adopted by WHO as a product called WHO Health Alert. It started off during COVID as a misinformation solution where we can help health workers to fight the whole idea of misinformation. But that went on to support their resilience as well. That went on to the iterations where now we are giving soft skills through that same software. And this is a free software that is available. It's a free messenger-based application that is available, which is promoted by WHO themselves. And we also have collaboration with Access Health, where we look at systematic reviews and creating spaces for FLWs in governance structures, what the work that we do with them. And we also have another partner who's called Dimagi, where we have developed WellMe application. It's a digital solution again for improving well-being of HCWs with a large focus on community health workers. This is currently deployed in a very large cohort in India, nearly 1,000 community health workers, where they are actively participating, and we are doing implementation research around that as well. So that is whom we are and what we do, or at least few of the things that we do. I would like to now draw your attention to something that has been very close to our heart. The TRC Toolkit. It's called the Resilience Collaborative Toolkit. It initially started off during the COVID again for the program managers, essentially, for them to be able to build or identify the right solutions for building their organizational capacity, or maybe even building the resilience of the people who are involved in their organization. So that was the seed for the Resilience Collaborative. So what we did is to see how is that we can upgrade this, because this was done for the for the context of COVID, and we wanted to move beyond that. And we had a consultative workshop where a very wide range of mental health experts and anthropologists and a very wide range of experts came together, and with large number of community health workers as well. So they all said one thing repeatedly, saying that, program manager, yes, they can, but it is again some solution that we are not participating in either decision making of saying what we want. So can you include us as an essential part of the solutioning, or how is that we can go on to do what is required for us on deciding, saying what is required for us, or probably we would be able to advise you and inform you better in terms of what could be the essential solutions that can build our resilience. So that is what became a trigger for us to extensively engage with community health workers to make this toolkit possible, where this toolkit we say is entirely developed by them now, with participation so much and so much of adaptations. And we recognize each and every one of them to be the co-owners of this particular toolkit. So we will be reflecting on saying what it meant in terms of the leadership and ownership when they participated in such exercises. So what was the outcomes that we see as part of developing this toolkit is it created that space for mental health conversation within the workplace, which wasn't happening thus far. And it helps them describe very clearly what their well-being and what their stressors are and what their coping mechanisms are. And it helps them sort of build solutions at a very simple level. We are keeping it at individual and group level, that they can action it themselves with very little resources. We hope that it will develop itself to a movement where they would be able to solution system level changes and be able to advocate using this whole tool for their own health and well-being, and also building their mental health. So that is how we see what this toolkit can achieve, and we see that happening in few places where we have validated it and where we have tested it so far. So these are some multiple validation points that we have had. In Ramnagara, Ramnagara is in a place in India where there is an entire workforce of a primary healthcare center, nearly 27 of them from different cadres. They participated, and they came up with their ideas, and they have started solutioning their resilience building solutions in a little way at the individual and the organizational level. We also did another exercise with 4 people in completely different place in India. So where they came up and they shared their stories and what it meant, the toolkit meant to them, and how is that they could likely own it. And we also have some of our TRC members who came across 9 people across globally. It's a global effort where they came up and they gave their ideas on saying what it meant to adapt it to their own context and using it in their own context. We also had a completely different context in terms of Male in Maldives, where nearly 70% of a private institution of all cadres participated, and they tested it, and they said, yes, it works for us as well and across the cadres. So this might be a good tool for us alone. And there they identified that this can be effectively used for the other staff within the hospital who are not necessarily professionals. So that was something that came out during that adaptation exercise and that validation exercise. And the last one we did was very recently, a couple of weeks ago, in a completely different place, in a tribal context. And it is an NGO run tribal hospital in India, where again a wide array of people participated, including CHWs. And they all felt that this really could improve the communication within the team and also help focus on the CHW needs when they get exposed to the field, and the challenges that they get to get exposed to the field in. So this is how we sort of make them the contributors to this whole effort, and we repeatedly send this message saying that it is not ours anymore, and they become essential part of it. So if you see that some nearly 114 people have contributed in developing these toolkits now, of which nearly 85% were CHWs as well. So that's CHWs. I would be including healthcare workers here, but a good amount of them were also CHWs. So if you see that all their names becomes essential part of the contribution list as we keep building these adaptations, and they all become the natural owners. So this is a process that we had adapted for this particular exercise or the activity that we actively do. What it means to, what it means to us in terms of, or what it meant to them in terms of the whole leadership aspect of this. So when we spoke to them about saying that, what does this toolkit mean to you, and what is that you see yourself being able to take up this activity for your own community or for yourself, the first thing they all realized during the exercise or as part of the conversations we had is their own challenges in being able to prioritize the self-care. We still remember a very clear message from one of the ashas or one of the community health workers. They say, see, we solely exist for the community, our family, and why should we be worried about ourselves? So I think that was one of the essential challenges that we faced in making them understand and be able to make them prioritize their own self-care. So that I think became reflection and a deep commitment for us to be able to develop them from that point to be able to lead and own these activities themselves. And one of the other challenges that we readily see is the idea of our well-being and the whole understanding of resilience is very different. And any of these conversations needs to begin with that, bridging the gaps of understanding understanding their lived realities, and them being able to tell us, saying that what it means and how do they conceptualize this whole idea of well-being and resilience. So that is where the conversation it needs to begin, is something that we have realized. And one thing that they all appreciated and really fall back upon is the peer networks. They see that that is where their whole idea of readership is also effectively expressed. This whole idea of peer networks and multiple levels. I think they all have their own levels of peer networks, and they all use it very well, is something that we repeatedly see. And strong openness to mental health dialogue. So once they realized that this was a conversation about themselves, I think they all opened up very easily, and they were able to really come up and share their thoughts, and some of them shared their symptoms still of saying what they are going through. And it was a much more open conversation that happened across the cadres when we put them all together. So, and they all of a sudden realized, saying that the doctor also experiences various stressors like just they do in their field. And that in its sort of sense of opened up of bringing them onto a similar platform, forgetting the hierarchies for a while when they were dialoguing about this whole mental health and probably co-creating solutions. And they do express a lot of excitement in being able to co-create solutions, though we stuck only to the individual and the meso or the organizational level or smaller community level. They still were very excited about thinking about the resources that they may need, and thinking about the permissions that they may need, and thinking about the support that they may need from different agencies and stakeholders was very exciting for them. And what we again do is to being all this exercise we hope is really building the agency. And they also say that yes, this is a tool now that we can effectively use for being able to talk about our mental health to any of the stakeholders. And this really helps us to be able to take our own issues into our hands, is what they said. So this is one of the reflections of the ASHA workers, what you see in a box. Sorry, that box is coming into the way of one of the sentences. So, so that's what I was reflecting upon, saying that, this tool is really helpful because no one comes and speak to us about ourselves. But I think such tools can really be helpful for them to tell their stories to the world and see what the solutions that they can adopt for their well-being. At this point, I will stop and I will ask the team to quickly run a poll. With me is a team that is part of TRC, and that is Dr. Shilpa Sadanan, Ashish Manva, and Shushri Nibetita Panda. And we also have a lot of our the Resilience Collaborative members here as part of this presentation. So I'm really thankful for everyone to make their time. I will hand it over to Shilpa, and if they can run the poll. Yeah.
Thanks, Vardu. While they run the poll, I'll keep talking. Sorry, I'm keeping my video off today because of the poor internet connectivity. Apologies for that. So let me take about 5 to 7 minutes just to talk about what's been our journey as the host or the secretariat of this global community of practice. Next slide, please. So just a quick background of community practice itself. So community practice is what? Organized groups of people who collaborate regularly around a specific area to achieve predetermined goals. Why is it really essential? We live in a very complex world with, so many different challenges that cannot be solved in isolation. So communities of practices connect people in very meaningful ways, so that we can learn and share with one another and have a greater impact. This resource is from the World Bank, and then they have a toolkit as well as to how to run a community of practice as well. Next slide, please. So I will be talking about two things when I talk about the global community of practice. One is just about the TRC structure, and then cover one component of member persona and engagement. So if you look at the TRC structure now, so the secretariat is us, and we as the TGI, the George Institute, host the TRC functions. And then we work closely with many implementation partners. But the core of this whole TRC structure is the community members themselves. And nearly 1/3 out of the 280 are healthcare workers or former healthcare workers who's been a part of the community of practice. And then this number doesn't include whatever Vardu suggested in the previous slide where we met. So that is additional to what it shows here. So these are the host functions, and then we continue to work across different ones. How do we sustain the COP? And how do we develop, and how do they build leadership, which Ashish will talk about in a little while. And then our core, being a part TGI, we also have a lot of focus on evidence synthesis and research work, innovations and prototyping and piloting, and also deploy some of the existing assets with partners and with the community members. So these are some of the components I spoke about. So what we really want to do is that in the future, probably institutionalize TRC if the community wants to do that, to continue to support healthcare workers, and the core team members, what Vardu mentioned, might not exit. And we really believe that healthcare workers will lead this TRC in coming years, and that's the hope we have. And what do we also want to do? Equip healthcare workers, by improving resilience through actionable insights, through the evidence synthesis and the research work, what we do. And also strategically disseminate some of the toolkit, some of the the research work, so that it can improve agency and insight to also influence policy. So as I mentioned, I will be talking about two things. One is that when we took over as the host of this community of practice, we felt that building the foundations was very key. So I think the whole of the first year from 2023, we also focused a lot of effort on technology and communications. How should be the TRC website look like? I think the trc.community was also decided by the community members themselves, the URL. And recently we were also in the social media to force more space and interaction. Data privacy and compliance was also a very key thing which we discussed. And so that if the healthcare workers want to take over as a community of practice, they should not have any difficulty with related to data privacy or compliance. They can, so with a lot of legal and operation and IT consultation. So this is a key process which we have worked. And we always believe that whatever decisions we make, the community decides for us, and not as the host team or the secretariat. And the member engagement and its challenges, which I will speak about. I think that's one of the things which we focused on. And then we've kind of developed, next slide, please. Yeah, so who is the key member or the primary persona for this community of practice? Because it's for healthcare worker well-being, we believe that healthcare worker should lead the COP. So that's the primary persona. Healthcare worker, middle management, organization persona, researcher, academician are the primary personas, and secondary personas are the practitioners or a leader, and the tertiary is the policymaker. So our core focus and the engagement or the goals, the primary personas receive the maximum effort and attention. Next slide, please. So, for example, this is the value proposition, and we have developed this value proposition across different member personas. So, if you look at the healthcare workers, we have the motivation and goals. What are the key challenges they face? How can the TRC, the Resilience Collaborative, can support in their goals? And what is the value to bring in more healthcare workers to be a part of this community of practice and also lead? So one of the things which we focused on is, of course, developing the resilience toolkits, which Vardu spoke about. But the other one was the career development, where we build on their leadership skills and advance opportunities. So, and of course, the lived experience, expertise, research influence, all becomes a core part of. So that's the value which will bring in more healthcare workers to be a part of this community of practice. Next slide, please. And this is the member journey looks like, but I'm not going to details of this because it's a very busy slide, but we're happy to share this whenever it's possible. The recording would be available, and also we can connect individually. But this is the whole member journey we worked on, that is to what should be the different levels of engagement across their journey with us. Next slide, please. And we also spoke, had the elements of as to what does a successful engagement look like, and what are the different key components which look into as to what should be a landing page look like. This is particularly to the digital space, and the events calendar. What is the communication channel challenges? How are the peer support networks? So all of this were actually developed to engage more meaningfully with healthcare workers. Next slide, please. And these are the different engagement levels. It varies in the community of practice. Some people just register and then not go beyond it. Explorer, is someone who is not active but passively consumes content, is a member, and someone is a leader who actually show initiative in leading discussions or group activities. And there are mentor experts, and there is advisory board. So across this engagement levels, we have different activities or required commitments to sustain being active in the part of this community. Am I audible? I see that Irene not able to hear me properly. Just checking.
We can hear you clearly, Shilpa.
Okay. Okay.
Yeah.
Okay. Thank you. Thank you. Next slide, please. And these have been the learning and insights over the last 2 years. I've been part of the community of practice or the community manager. I think building the foundations right is very key. Having everything sorted. Why do members want to come back? Is that the assets and resources which brings them back. And research and evidence synthesis and the strategic dissemination also becomes a very key part of the community of practice. And I cannot, it's very important is to build relationships, but also building relationships meaningfully also brings in a lot of challenges. It needs a sustained effort to connect with members, partners, and also diverse channels of communications. And we've found that having initiatives such as myTRC, leadership is ownership, is also very important and brings in a lot of community interest as it supports their career development as well. And the last two points I want to say is the voices and stories from the front line. I think when we initially took over as the host of the secretariat, we really believed that lived experience is important. But I think over the last year, we have realized that it's very important to share the voices and stories from the healthcare worker themselves with the broader community. And what's been really, really meaningful as part of this community of practice is meeting healthcare workers and different healthcare workforce across diverse communities, and bringing in their perspectives, I think has played an undeniable and crucial role in shaping and managing this COP. So I will stop there, and then probably I can take more questions in the end. Thank you, and I hand it over to Ashish. Over to you, Ashish.
Thank you, Shilpa. Checking if everyone can hear me all right.
We can, Ashish.
Super. So welcome again, everyone. I know you've been patiently listening to this, and we're having a little bit of trouble, everyone, for those of you here who are here, that there are some people still stuck on the outside of this session. So we're asking the team to help them get in. So we are going to briefly speak about the leadership experiment here, and I'm going to really lay the context and then hand over the floor to many of our colleagues here who could make it into this conversation. So fundamentally, our focus here is the learning from the leadership work with the community healthcare workers. So really, it's about the idea, it's about the experiment that we had run, and we want to share some of the learnings coming out of this. So what really is this program, and what is it that makes it really relevant? So I'm going to speak a little bit, and then I'm going to invite the others as well. You can go to the next slide just to show who the cohort members are. Some of them are here. So Rita, I think she's still knocking in to get in. Dr. Arshi's here. Gladys and Umar, part of this. Even you're here. Neelam, I'm not sure she's been able to make it. I can't see her. Maybe she's here. Christina and Dr. Asha as well. So we're going to be having them share their experiences, but I'm going to lay the context and you can go to the next slide, please. So the question really is, what is this experiment? And very briefly, the myTRC leadership as ownership is fundamentally organized as a co-designed program for about 9 months. And this is really meant for healthcare workers across the globe, with two goals in mind, the ones that we had organized it. One is so that we can find ways of supporting community healthcare workers with the ability to lead in their own context, whatever that might be, in terms of an organization or a community, or even temporary stages where they might need to step in. And the second is, how could they actually contribute to the TRC community, take on roles in which they can lead elements of advocacy or different programs. Broadly, that was what we wanted to create a platform for. I can talk about the structure a little more. The next slide. And this was organized as focusing primarily on the self, because I think that's one area that many healthcare workers, you would all agree, with the intent of serving others, sometimes forget that you also need to take care of yourself. So focusing really on the self, about how do you organize your thinking, your time, yourself, before you begin to be in a place of leading others effectively, and then similarly working your way towards leading others. Maybe if I can speak slower or work for Yvonne. So yeah, that's really the structure. And the next question we need to really address is why, or what makes it relevant? Healthcare, leadership. What's the connection? What really makes sense? Yeah, the next slide is fine. We can be there. And so this is somewhere I would invite you to maybe respond in the chat as well. For us as the team who are working on putting this experiment to structure, just by virtue of healthcare workers being on the front line, the nature of care, the work with the community, and the difficult context you all find in, and still remain committed to the initiatives or the sacrifice and the way that you focus on others' interests before yourself, that really constitutes leadership. It might not be ones with formal titles, but it is very practical, high-risk, action-based work. So I wonder if you agree with that form or understanding of leadership. If you want, please go ahead and maybe respond on chat, whether that aligns with your view of leadership. The context and scope might vary, as we understand. You could be a solo person. You might be leading a small team, or maybe a community of 20, or even hundreds of families in your village. But the fact is, the very nature of your work being placed in challenging situations, often in the healthcare context of life or death, conflict and distress, the very fact that healthcare workers are taking initiatives and providing care and finding solutions, even with low risk, that sets apart. So that nature of servant leadership, which is already functional, in our view, is very crucial as a functional and existing leadership, but often without resources and in a sense of loneliness as well. So I wonder if any of you agree or disagree with that form or our description of how we've looked at leadership. But that sense of loneliness has been one of the elements in which tried to address the need. So maybe go to the next slide. So through the myTRC work and the advisory panel that Dimagi has been leading with the Wellme Group, which really influences how the app is shaped for the well-being of the healthcare workers. Some of these learnings are we're going to be speaking about. So let me quickly summarize in the next slide what these elements of learning have been. Yeah, we can move forward. So again, in a maybe couple of minutes, I'm going to invite you, Dr. Arshi, Iverin, just wondering who else is here from the cohort. Yeah, we'll just have you folks join in, but these are your quotes. So I'm just phrasing it for the community here and for people who are going to probably look at this recording later as well. But broadly, the learning from the leadership engagement has been one of really, authentic leadership. It's not about titles, as we spoke about earlier. It's really about initiative, taking ownership and moving forward. It's about the willingness to acknowledge limitations and biases and knowing where exactly you have the span and scope of control, which is what you've been working at. The awareness of what might work, what doesn't work, pursuing excellence. In other words, you really care, and you focus on quality, and your determination focuses on elements. So the level of excellence is about learning how to make sure you're effective, and moving forward to demonstrate ownership over every activity that you've been given. So, and then the final point, I think, which most people would struggle with, is the element of self-worth. I think in the busyness and the focus of trying to deliver value, sometimes there's a natural self-sacrifice which causes you to forget yourself, and that leads to a lot of stress and distress. So some of these elements have been key highlights that we've noticed for the leadership cohort. But I'm going to now hand over to the group here. The next slide, or we can go to the next one. So maybe if we'd invite you to share your reflections, Chi, Iverin, about what is, in terms of your experiences how has your experience within the TRC been so far, and what is the experience within the myTRC process, the entire coaching, the working with each other on practical elements. How has that impacted your leadership today? And how do you think that is impacting your leadership going forward in terms of your journey? So we just want to keep that open, and please unmute, and I invite you to share your ideas.
Hello everyone. Good day. So I'm Dr. Arshi Ahad, this cohort, as briefly mentioned by Ashish. Thank you so much. I know, it's like days are passing so quickly. We just started in the month of July and it's already November. And in the month of March, we are going to graduate. So I'm having a bit network problem. Is it fine if I just switch off my video? Am I audible?
That's fine. You're clear. We can hear you clearly.
Okay. So my journey with my TRC has genuinely changed the way I understand leadership. Earlier, I just used to associate leadership mostly with responsibility, delivery, and being the person who gets things done. But through this, I have started seeing leadership as a much more reflective and relational process. The exercise, which we have already done, especially the ones that made me examine my patterns, motivations, and the way I respond under pressure, helped me really slow down and observe myself with more honesty. It just repeatedly brought me back to the ideas that leadership begins with self-awareness. I realized that the way I think, react, or take decisions does not just affect me, it also shapes the entire group's emotional tone, direction, and confidence. Well, this was a big shift for me. It also made me notice that how my strengths, like being organized, sincere, responsible, and proactive, can become even more powerful when paired with reflection, empathy, and presence. So, going forward, I see these learnings guiding me to lead in a more grounded way, like to pause before reacting, to understand the energy I bring into a space, to communicate with intention, and to hold people and tasks together with balance. So, like it has essentially taught me that leadership is not just about stepping up alone. It is about showing up consciously, and this is something I know it is going to stay with my in my leadership journey. One of the biggest changes for me has been how I show up in group settings. Earlier, I used to focus more on content preparation or getting things right. Now, I pay attention to how I participate, the tone I bring, and how I engage with others in this TRC space. So, yes, it has shifted me from being a task oriented person to being a people and process aware leader. And I know this will influence my future leadership, especially as I move into roles where collaboration, trust building, and reflective decision making are essential. So, yeah, thank you so much.
Thank you for sharing.
Okay.
We should probably have.
Sorry, can you hear me?
Yes, we can.
Okay, so for me, the myTRC journey has really been a humbling one, because I have in my personal life had a season of health challenges while on the program, and I've come to see that leadership is something that you cannot do alone. I've come to have support, not just from myself, but from the team as a whole. And I've come to see that leadership is a thing of accountability. It's so much about accountability. When you are, when you acknowledge that you don't have it all, then you can do better. So at the beginning, I have always been this kind of person who has always felt like a superwoman. But I've come to see that when I acknowledge that there are those who have gone ahead of me and I can draw from their strength and from their wisdom, I will be a better leader. And when I operate with my fellow team members, even when I'm not able to carry myself, they're able to, enable that the team moves ahead. So it's been a humbling experience, and it has enabled me to see leadership beyond just a title, but as a teamwork that at the end of the day it takes the whole village to deliver. So it's really been a learning curve for me and a mental shift for me, and I'm grateful. And the beautiful part of it is the resources that you keep bringing on board in the myTRC program to build us as leadership. So leadership places you in a place where you keep developing yourself, you keep building and sharpening yourself and being up to date so that you can deliver your best. And it has also put me in the place where initiative, there is that demand on me to have more initiative. As I see problems, how can I be the solution? And I'm more sympathetic also to other healthcare workers, because I'm like, okay, I'm getting a lot here. How can they also get it? And I'm looking forward to developing something that will enable me step down what I'm gaining from the myTRC program. So it's really been a blessing. Thank you very much. Over.
Thank you, Evelyn. May I also ask you, Evelyn, if you can briefly share your context, where you're from, what you do, so all the community members here can just relate?
Can you hear me?
Yeah, we can hear you.
Okay. Oh, I can't hear you. Sorry.
So I said, if you can briefly introduce your work and your context. I'll put that on chat. That's fine. But I want to open up the floor really for everyone please feel free to unmute, get on your cameras. We'd like to just hear from you as well about your reflections. So far, we've spoken about 3 elements of the leadership part of the Resilience Collaborative in terms of how we are engaging with different parts of the world in terms of building resilience toolkits, how to have find ways of supporting the mental health and recovery, finding ways in which we can build a platform, but also supporting individual and healthcare workers' leadership journeys. We want to hear from you. What do you feel has been important in your context in terms of leadership? Where do you think you've really struggled, and where do you think there is value? So we just want to open it up really for a conversation. Yeah, you're welcome to just unmute. Magadhi, please go ahead.
Oh, sorry. Can you hear me okay?
Absolutely.
So as someone who employs CHWs and as the leader of the organization, one of the things that I saw when I first started in my position was the lack of awareness, and the culture was not there to support CHWs, to grow them, to really wrap ourselves around them and help get them to where they were, to where they wanted to be. And so one of the things that we had to do was we went on a 3-year journey to change the culture of the organization, to implement more awareness, role awareness specifically, especially with the supervisors and what it takes to supervise CHWs. And we really created a learning and growth environment. And I can say that in previous organizations that I've worked in, that's probably the biggest barrier, is when leadership doesn't cascade down the trainings, doesn't cascade down the culture. And so it gets stuck somewhere in the middle, and the CHWs are the ones that suffer. So I can say, as someone who is a CEO, that we've worked really hard on that, but it's just very difficult if everyone doesn't buy into it. So it's something that has to happen at the top and come all the way down. Thank you.
Thank you, Margaret. I think that's really crucial. You as an organization leader have, sort of a perspective because you've engaged with healthcare workers in different contexts as well. So your perspective is fairly rich, but we also realize that that so many of our healthcare workers, our colleagues, are in places where they're delivering value and actually in leadership, but do not have either the title or the support that goes with it. So the mentoring and the related support that is necessary for thriving as a leader, because being a healthcare worker comes with its own stress, but being a leader as a healthcare worker, that's asking for a lot, and I think there's a lot we can be very grateful to the healthcare community. But yeah, back to all of you. Anybody else has anything to add or raise as a question? Fardu, back to you as well.
Yeah, it's really nice to hear people who have gone through this journey. Thanks for sharing that, Magli. I think it will be a great learning for us as well as TRC to see that process of how that organizational change happened. I'm sure it is there, and if we could share that, I think that will be really helpful for us to understand those journeys as well, which we can make it as part of our learning systems as well. So we'll get back, get in touch with you. Already are in touch with you. So we will see how we can explore that to be able to take that learning, which I think is a very key learning. Yeah. So thanks for sharing that. Others, the others from other contexts, is there anything else you would want to share about the ways that you found interesting to build, or maybe the processes that you used that can help others as well in this session?
Yes, I would like to add more towards about our journey. So basically, I introduced, of course, myself, and right now I'm in Gurgaon. So I'm just going to mention a brief about my TRC journey, like what all we have done till now. So we have been a part of a structured learning and self-development process. We have regular master classes where we learn new concepts and skills. And every month we also get specific tasks to complete, which help us apply like what we have learned in a more practical way. And along with this, TRC also provide many tools, worksheets, YouTube learning videos that support our growth. And the major part of a journey is also self-analysis, reflecting on our progress, strengths, and areas we need to improve. So overall, it combines learning, practice, and reflection to help us grow professionally and personally. There are teams, and in each teams there are few members, 3 to 4, and among our members, one of them is the leader. So yeah, there is also point like who is leading at what position. So basically, yes, this is our skills development which are going on. And yes, in the month of March, it will complete and we all are going to graduate at that time. So yeah, that's it. I just wanted to give a brief overview like what we all are doing right now.
Thanks for that, Ashi. Yeah, it would be good to hear from Christine and David as well, being part of the session. What would be your key takeaways from this session? Can you please unmute yourself and share? Yeah, Christine, please go ahead. Yeah. Please go ahead, Christine. Yeah. David? Yeah, please go ahead, Christine.
They said
We can hear you, Christine. Please go ahead.
I think you've probably muted yourself, Christine.
I think maybe you should type a message to her.
okay, you can hear me now?
Yes.
Thank you.
Okay, thank you so much. This has been a helpful session, especially for us who work with CHWs. In leadership, what does it mean? Being at the front in whatever we do, giving them opportunity to serve, giving them opportunity to unpack the concepts instead of saying, these are concepts someone has to lead. For them, maybe their level is to do implementation. At all level of leadership, when we're implementing, integrating, their expertise is key and involvement is key. Participatory approach is the best. Involve them, tap on their best expertise, and if train them, support them, they can ably do better. And also, if a call to all our presenters, we can ably support the community health workers by putting up strategies, by putting up a force, as this conference, it's a huge force behind CHW's work. So putting up a force that people can give them leadership, people can flaunt them, people can support them, being a force for advocating their work, but also supporting them to ensure that they are ready to fulfill those positions. Thank you.
Thanks so much, Christine. David, do you want to share something, David? Okay, I think we can move on. I will hand it over to Dr. Shilpa to close this session. Over to you, Shilpa.
Thank you, Vadhu. Thank you, Ashish. So just wondering what could be a key takeaway, which, or a highlight from this session. That would be if you can, unmute and share it with us, or, you can type it in the chat box. For me, I think the challenges. I think many of our TRC members and the myTRC cohort had difficulty to join in today. Really, we can share the recording with them, and I think with all the preparations also, it will also tech also kind of makes it challenging, and I think that could also add to our COP management, which I was speaking about a little early. But feel free to type in as to what has been your key takeaway from this session. And we always welcome you to go and check our TRC website and then follow us on LinkedIn. So we keep posting updates about the work we do with healthcare workers across different regions.